Dear colleagues and friends, Happy New Year. On behalf of my co-authors, I'm delighted to share with you the highlights of the updated ISUOG guideline on the role of ultrasound in twin pregnancy. And the previous version was published back in 2016. The scope of the guideline is wide, covering from the routine assessment to also diagnosis and monitoring and management of complicated twin pregnancies, but really focuses mainly on the role of the ultrasound. When determining gestational age or dating twin pregnancy, we decided to keep the previous recommendation of using the larger crown rump length in the first trimester or the head circumference after 14 weeks to date the pregnancy. Despite the fact of the recent evidence that suggests that perhaps maybe using the smaller twin or the average might be more accurate, we still felt, or the consensus was the fact that we keep the previous recommendation for two reasons. Number one, there's no evidence that by using the larger twin that you increase the number of twins diagnosed as small for gestation age, and also there's no really evidence that using a different approach improves the pregnancy outcome. And of course, for pregnancies conceived via IVF, we should date the pregnancy according to the age of the embryo and the date of transfer. About the routine monitoring of twin pregnancies using ultrasound, and to some extent there is no significant change. So both dichronic and monochorionic is an assessment in the first trimester, including dating, labeling, chronicity, and assessment of the risk of chromosomal abnormalities. And in dichronic twins, from 20 weeks, every 4 weeks until the end of the pregnancy, because you're monitoring for fetal growth restriction. And in monochorionic twins, from 16 weeks, every 2 weeks until the end of the pregnancy, because you're monitoring mainly for twin-to-twin transfusion syndrome, and as well as also TAPS. About the Doppler, and what's the role of the Doppler in the routine assessment of twin pregnancies? And certainly guidelines do vary, but in the ISUOG guideline for dichronic twins from 24 weeks, we recommended umbilical Doppler as a routine assessment. And of course, both in dichronic monochorionic twins, we will calculate this with fetal weight discordance. In monochorionic twins, we did recommend that we start a Doppler from 20 weeks, and I know it's controversial. For the monochorionic twins, as I mentioned, with the frequent assessment, because we're monitoring for monochorionic related complication like TTTS and TAPS, but also selective fetal growth restriction. And therefore, this is the ultrasound images that you expected to obtain in this assessment. And as I mentioned, in monochorionic twins, the consensus where we start routine assessment of the umbilical artery Doppler and the middle cerebral artery peak systolic velocity from 20 weeks for the MCA peak systolic velocity to monitor for TAPS. For screening for chromosomal abnormality, in the previous guideline, we did acknowledge the fact that the NIPT or the cell-free DNA is the seems to be the most accurate test, but the data was limited in twins. But now the most recent meta-analysis have data for more than 33 or 34,000 twin pregnancies, and therefore the recommendation in this updated version is the fact that the most accurate test for trisomy 21 in twin pregnancies is cell-free DNA, and that can be offered from 10 weeks for 18 and 13. For other trisomies, of course, the data is less or more limited. What about if an IBT is not available or is not a routine practice? In this case, the screening should be using the combined test, or if you don't have the beta-HCG and BAP-A in twin pregnancies, a combination of maternal age and nuchal translucency. What about the cases of vanishing twin? And we recommended that we just use the nuchal translucency in combination with maternal age. And an alternative is we can use the nuchal with maternal age and beta-HCG. A study suggested that we could adjust the level of the BAP-A, but we felt that still we need more evidence before making this recommendation. And in fact, actually, certainly if you look at the recommendation by the other professional societies, several of them do recommend offering cell-free DNA in twin pregnancies for screening for trisomy 21, including the American or the SMF, the ISFD, and now also the ISUOG guideline. For invasive prenatal diagnosis in twin pregnancies, we did recommend that CVS is preferred or should be preferred to amniocentesis in dichorionic twin pregnancies, primarily because it provides an earlier prenatal diagnosis, and that means the option of earlier, safer, selective termination if necessary. While in monochorionic diameter twin pregnancies, particularly if it's complicated by discordant anomaly, in this case, we should consider the option of double amniocentesis in view of the possibility of heterokaryotype. Important just to highlight the latest evidence on the risk of pregnancy loss before 24 weeks or preterm birth less than 32 weeks in early versus late selective termination of pregnancy with a cutoff of 18 weeks, is slightly different from the figures that we usually used to quote. So less than 18 weeks, 1% pregnancy loss, 3% preterm birth less than 32 weeks, compared to 8% and 20% when it is performed after 18 weeks. Whether amniocentesis or CVS in twins increase the risk of miscarriage, and certainly the evidence has been controversial in the literature, and we summarize this evidence in the guideline. I'm not going to go through that until now, but certainly it seems that there is no significant difference in the risk of pregnancy loss in the twin pregnancies that underwent amniocentesis versus those who didn't, take into account the background risk of pregnancy loss. So in this meta-analysis was 2.4% in those groups. And for the CVS, similar, you see 2% versus 1%, 1.8%. Again, there's no significant difference. Having said that, just to acknowledge that there's been some studies where maybe have adjusted for potential confounding and also reported that CVS was not an independent risk factor of the risk of miscarriage. Some used other statistical methods and maybe reached different conclusion. But the consensus is that potentially, actually, probably, the risk of miscarriage is probably less than 1%. About screening for preterm birth, in the previous guideline, we did recommend to offer cervical lens as a preferred method to screen for preterm birth in twins with a cutoff of 25 millimeter in the second trimester, so between 18 and 24 weeks. What's different or what's new in the updated version, that we also recommended that in twin pregnancies, there's an additional risk factor that we should consider doing an additional cervical lens assessment, again, prior to 24 weeks, acknowledging that the longitudinal changes in cervical lens could differ with the different risk profile of preterm birth. What about prevention? Acknowledging again, in view of the evidence, we did not recommend the prophylactic use or routine prophylactic use of progesterone in unselected twin pregnancies to prevent preterm birth, while actually in those who have short cervix, 25 millimeter or less in the second trimester, we did recommend use of prophylactic use of vaginal progesterone. What about in twin pregnancies that present with a cervical dilatation in the second trimester? And in these pregnancies, they tend to have very high risk of preterm birth, more than 50 to 60% before 28 weeks, and very high risk of perinatal mortality, maybe approaching 60%. And acknowledging that the evidence from randomized control trial that actually using physical exam indicates cyclage or emergence cyclage in combination with endomycin and antibiotic did reduce the risk of preterm birth with various cutoffs in the group that had the cyclage compared to the group that had the expected management. And you see the significant large difference. Again, I know it's a small randomized control trial, but still considering the evidence and the fact that also the perinatal mortality almost 80% lower, so 18% in the cyclage versus 77% in expected management. So in view of that evidence, we also make a recommendation related to the role of cyclage in this group of women. What about the cyclage only in women with dilated cervix? What about in a very short cervix, so less than 15 millimeter? And in this meta-analysis, we did look at also women who twin pregnancies with cervix less than 15 millimeter or open cervix, and the evidence suggests that actually it is associated with lower risk of perinatal loss and adverse composite adverse outcome. And therefore, based on this recent evidence, we did recommend a combined strategy of a physical exam, indicates a class of the emergency class in combination with antibiotics and tocolytic, may be considered in twin pregnancies with dilated cervix in the second trimester or before 24 weeks. And also the cerclage may be considered in twin pregnancies with a very short cervix, less than 15 millimeter before 24 weeks. For fetal growth restriction, similar or consistent with the previous guidelines. So how to assess the biometry of growth in twins, equations or estimated fetal equation that combine head, abdomen, and femur. And it's very important that we calculate the inter-twin discordance at every scan from 20 weeks. And if the discordance is 25% or more, the indication to refer to fetal medicine specialist. And for the diagnostic criteria of selective fetal growth restriction, if you have estimated fetal weight of one twin less than 10 centile, combined with estimated fetal discordance of 25% or more. But certainly acknowledging the diagnostic criteria do vary and acknowledging the Delphi or the consensus diagnostic criteria of selective fetal growth restriction, whether in dichoric or monochorionic twins. If you have one twin with estimated fetal weight less than 3rd centile, that's enough to diagnose selective fetal growth restriction twins. But if you use a conventional cutoff of estimated fetal weight less than 10 centile, you need to have, in addition, discordance of 25% or more or abnormal umbilical artery Doppler. What about the management of this pregnancy? So twin pregnancies complicated by selective fetal growth restriction. And despite the fact that we don't really have level 1 evidence from randomized controlled trials and really limited evidence from observational studies, we did recommend that in dichorionic twin pregnancies complicated by selective fetal growth restriction, they should be followed as fetal growth restriction in singleton with slight differences, which I'm going to mention in a second. While in monochorionic twin pregnancies with selective fetal growth restriction, where of course there is a risk of demise or brain damage of the co-twin if the smaller baby were to die. In this case, the options are either conservative management with early delivery or active fetal intervention using laser or selective termination using cold occlusion or radiofrequency ablation. How often should we follow up this pregnancy? So in dichorionic twins with selective fetal growth restriction, at least every 2 weeks, maybe more often, depending on the Doppler. Monochorionic twin pregnancies complicated by selective fetal growth restriction, at least weekly. Of course, if there is evidence of substantial risk of fetal demise with a smaller twin, like reverse A-wave endoductus venosus, in this case, we should consider delivery after 26 weeks. If it's before 26 weeks, we consider active fetal intervention. For monochorionic twins, again, based on observational evidence, the delivery for selective fetal restriction Gratakos type 1 was positive in the systolic flow and the umbilical artery Doppler, the delivery at 34 to 36 weeks, while in type 2, Gratakos or type 3, 32 weeks or earlier if there is evidence of deterioration. Something different in the updated version of the guideline is the threshold for delivery in dichorionic twin pregnancies complicated by selective fetal growth restriction. And as I mentioned earlier, the recommendation generally is to treat them as a singleton. Again, reiterate the limited evidence to support that. But actually, because of the potential risk of iatrogenic prematurity of the larger twin, in this case, before 29 weeks, the recommendation is expectant management and not to deliver unless for maternal indication, for example, like preeclampsia. While at the threshold to deliver here using the Doppler or using the computerized CTG or the biometry, and again, there's based on very limited evidence on computerized CTG in twin pregnancies, but being pragmatic and consensus or the fact that you extrapolate from the evidence on singleton on twins of dichorionic twins. So the threshold twin, if the ductus venosus has reverse A-wave or the STV is less than 3, it delivers from 29 to 31 plus 6. If it is reverse in the endosolic umbilical Doppler or STV is less than 3.5, 32 to 33 plus 6. If it's opposite in the endosolic umbilical artery Doppler or STV less than 4.5, deliver 34 to 35 plus 6. And if the umbilical PI of the 95th centile, or the smaller twin have a CO estimated fetal weight less than 3rd centile, they deliver from 36 weeks. For single intrauterine demise, the evidence is the same as the previous guideline. So this is useful figures to use to counsel the parents about the risk of demise of the co-twin, preterm birth, the prenatal abnormalities and neurological abnormalities. And you can see that obviously the risk is much higher in monochorionic versus dichorionic. Preterm birth is high in both, and the fact acknowledging that the preterm birth risk differs according to the gestational age at single intrauterine demise, being higher in the 3rd trimester or later in pregnancy. In monochorionic twin pregnancies complicated by single intrauterine demise, acknowledging the potential risk to the surviving twin and the importance of assessing the hemodynamic circulation using the MCA peak systolic velocity and the follow-up of this pregnancy and the role of the MRI to look for the prenatal abnormalities. The role of the MCA peak systolic velocity certainly has been the subject of some controversial or studies acknowledging that's associated with the risk of long-term neurodevelopmental impairment, but whether actually if you have increased MCA peak systolic velocity in the surviving twin, whether doing endocrine transfusion is associated with better outcomes or not. The evidence is controversial, and also the practice varies. A complication unique to monochorionic twin pregnancies, so TTTS and obviously TAPS in particular and TRAP. The TTTS is polyhydramnios oligohydramnios sequence, oligohydramnios deepest vertical pocket less than 2 centimeters. The polyhydramnios, the cutoff varies, acknowledging that in early gestation it's reasonable to use as a lower cutoff of 6 centimeters instead of 8 centimeters, and also acknowledging the fact that there is evidence that this 10 centimeters beyond 20 weeks compared to 8 centimeters before 20 weeks is also controversial, because the fact that between 8 and 10, there are some pregnancies were associated with poor outcome. Staging, we still did recommend Quintero staging. And as I mentioned earlier, for the monitoring for TTTS from 16 weeks every 2 weeks until the end of the pregnancy. What about if you have a discordant amniotic fluid volume, but not TTTS? So what do you mean by the discordant? So the cutoff is 4 centimeters. In this case, the recommendation is to monitor them weekly, looking for progression. But these pregnancies have good outcome with overall survival more than 90%, low risk of progression, severe TTTS less than 15%. What about the treatment? Of course, the stage 1 randomized control trial that was reported and was negative, acknowledging or sort of concluding that laser is not necessarily beneficial in stage 1 TTS, but very important in women with asymptomatic with a long cervix. So if a woman TTS stage 1 symptomatic or have a short cervix, in this case, we should consider offering laser surgery. And therefore, the recommendation is that laser treatment is a choice for Quintero stage 2 and 3 and 4, but also for 1 if it's symptomatic or with short cervix less than 15 millimeter. But certainly, if the laser is not available, in this case, serial induction might be acceptable alternative beyond 26 weeks. When do we deliver pregnancies? The evidence is controversial, is really limited, but there's some evidence that maybe perhaps we should deliver them in 34 weeks, but the practice varies. Some would continue, if it's completely uncomplicated, after the laser surgery to maybe up to 36 weeks. For the TAPS, which is the discordance in the hemoglobin level, so one twin is anemic and one twin is polycythemic. Secondary, this is very small anastomosis in the placenta, with incidence of about 3 to 5% in spontaneous and about up to 10 to 13% after the laser. So the majority of TAPS occur after the laser. And in terms of the diagnostic criteria, the previous or the original one, peak systolic velocity above 1.5 mom in the donor or the anemic and less than 1 in the recipient, but also take into account the recent evidence that suggests that actually the delta of the difference in MCA peak systolic velocity has better sensitivity with various cutoffs, whether the delta 0.5 or 0.373. That's really sort of created controversy in terms of how we diagnose TAPS, and also the Delphi consensus, which concluded that 1.5 mom, a cutoff for the anemic twin, but maybe 0.8 mom rather than one mom for the polysystemic, and the discordance of one mom. So just acknowledging really that there is a different diagnostic criteria that's been proposed in the literature. The management of TAPS, number of options, no randomized control trials. There is ongoing randomized control trial, the TAPS trial, and we're waiting for the results to hopefully give us guidance about what's the best management. But the options are expected management, particularly in mild cases, preterm delivery, especially in TAPS late after 32 weeks. Most fetal medicine centers do offer laser therapy, transfusing the smaller baby in exchange for the polysystemic twin, or selective termination, particularly if it's early onset, severe, or associated with discordant anomaly. Certainly, these options, it seems the evidence, the perinatal mortality is relatively similar in these options, except of course for selective termination, where the perinatal mortality is less, but by the definition, obviously you have less babies surviving. And similarly, the severe neonatal morbidity, again, seems to be similar, or no significant difference among the various options. The time to delivery seems that maybe there is a difference in the time to delivery but among the various options, and hence, as I mentioned, the TAPS trial is ongoing, and hopefully will give us guidance on what is the best management option in cases of TAPS. And therefore, the recommendation was the fact that, yes, we diagnose TAPS based on the discordance in the MCA Doppler. The fact acknowledging that there is limited evidence, and therefore the treatment should be individualized, depending, take into account severity, and take into account, of course, the gestation and the parents' wishes. But in the ISUOG guideline, similar to the previous one, we did recommend that we should monitor for TAPS and all uncomplicated twin pregnancies, monoclonal twin pregnancies, and on those who are had laser surgery for TTTS. And that's, again, there's been controversial among the various guidelines, but I'm aware that some guidelines have started actually recommending monitoring for TAPS. How can you prevent it? Yes, the Solomon technique, when you do the laser for TTS, it has been shown to obviously reduce the risk of post-laser TAPS. So as I mentioned, this is the monitoring or the pathway that we recommend, was recommending the MCA extracellular velocity from 20 weeks on all monoclonal twin pregnancies. What about TRAP, or twin reverse arterial perfusion, where there is the intertwin anastomosis with blood from the pump twin going to the acardiac twin. So the TRAP, or the acardiac twin, does not have cardiac activity and have various malformation. Often the comments is the lower part of the body that's formed, while you don't see the upper part, but there are various forms of TRAP. The management options, whether intrafetal laser, which can be performed in the first trimester, or radiofrequency ablation, or the laser, or the cord occlusion, all these prenatal interventions, the survival rate have been reported to be about 80%. The main controversy about TRAP is the timing of intervention. Most of the cases of TRAP are diagnosed in the first trimester. So should we offer the prenatal intervention in the first trimester, or should we wait until after 16 weeks? Because some of this TRAP, there will be spontaneous cessation of the blood flow in the acardiac twin. I think the problem is that while you are waiting between 12 and 16 weeks, there is a significant loss in about maybe up to 50% of the pump twin. So, and therefore the controversy, as I mentioned, is on the timing. Do we intervene in the first trimester, or wait after 16 weeks? And this is a question is currently being addressed in the TRAPPIST randomized control trial. So I hope that I give you a really very broad coverage or highlights of the updated version of the ISUOG guideline on twin pregnancy. I hope that you find it useful for your practice, and I really hope that you enjoy reading the article. Thank you very much for your attention.